Chapter 9, Evaluation of the Acute and Medically Complex Patient. Older adults are the fastest growing age group in the United States, as we've discussed before. There are so many contributing factors to disease and disability in this age group, and a lot of these have to do with physical inactivity and sedentary lifestyle, which as physical therapists, we can play a huge role in reversing some of the problems that come with both of these two activities or inactivities. So thinking about the evaluation that we would do with the patient, regardless of the setting that we're in, we want to make sure that we do a thorough evaluation as much as we possibly can, develop a proper plan of care based on the information given to us both subjectively and objectively, make appropriate discharge recommendations, and then facilitate discharge planning depending on the facility and type of facility that you're in. Chart review is one of the first places that we would start before we would see a patient. If we're in an acute care setting or skilled nursing facility, we might have more of the hospital-based records, or even an outpatient in a hospital-based setting. You're going to have more records than, like myself, I don't tend to get a lot of hospital records or records from the physicians per se when dealing with outpatient facilities that are more of a private practice setting where we don't have access to the full chart. You want to make sure that you're looking at all available documents because this can give you a lot of information before going in to see your patient, and making sure that you understand the reason for the visit or the admission. As you go through that chart review, you want to start making a problem list of what you think you might see when you walk into the room or start working with your patient. One good way of getting some information is looking at lab values. Blood work can give you quite a bit of helpful information, and I think this is a really important thing, especially if you're working with a medically complex patient, to figure out what might be going on with them or things you need to be mindful of when working with your patient. The CBC complete blood count measures several components and features of the blood, including red blood cells, which carry the oxygen, white blood cells, which are going to fight infection or show you that an infection might be brewing, hemoglobin, which is the oxygen carrying protein in red blood cells, hematocrit, the proportion of red blood cells to the fluid component or plasma in your blood, and platelets, which help with blood clotting. Abnormal increases or decreases in all these different cell counts reveal what might be going on with your patient and can give you some ideas of what to be mindful of when you're working with the patient. Looking at albumin levels, which gives us kind of the protein levels and tells us a little bit about the nutritional state of our patient, can be helpful as well, because patients might be more fatigued due to poor protein levels in their body. And arterial blood gases, looking at the oxygenation state of the body as well. You can also use the patient, family, or caregiver to get as much information as possible to help you determine the best course of action when it comes to working with your patients. Review of systems. Are there other systems or other things that we need to be mindful of, and maybe make a medical referral for this patient, or things that we want to look at specifically when we do the evaluation to determine if a medical referral to somebody else might be appropriate for this patient. One of the most well-established risk factor screenings is for coronary artery disease, and CAD is the leading cause of morbidity and mortality in the older adult. 80% of deaths related to coronary artery disease are individuals age 65 plus. So looking at the heart health is a really important thing to do with all of our patients, especially the geriatric population. So when you're looking at all this information that you have, does it give you an idea of other tests that you want to take away from or add to the evaluation that you want to do day one to start to form a picture of how best to care for your patient? Mental status. One of the things that your book talks about is specifically delirium, and delirium is defined as an acute decline in mental status associated with transient changes that in many cases can be reversible. There are three states of delirium. The hyperactive state, not surprisingly, this just means the patient's going to be restless, maybe agitated. The hypoactive state, your patient's going to be a bit more lethargic and withdrawn. And then the mixed state, where patient behavior might fluctuate between the two other states, the hyperactive and the hypoactive. This can, quite a bit of the time, be misdiagnosed as dementia. And this can lead to high mortality rates, especially if somebody might be a bit confused and restless trying to get out of bed. Maybe they're not safe to get out of bed on their own. So we need to make sure that we're noticing if we're seeing signs of change in this, in the behavior of the patient, especially if you've been working with the patient for a while and all of a sudden they're starting to act quite a bit different than what they did originally, making sure that you're alerting the doctors or nurses that are caring for this patient to get them the help that they need. So features of delirium could be acute onset of inattention, disorganized thinking, change in their level of consciousness, disorientation, decreased memory, perceptual disturbances, and then altered sleep-to-wake cycles. Studies that have been done show that the incidence of delirium in the ICU can reach upwards of 90%, which is a little bit disheartening and scary, knowing that the patient is in an altered state already with medical issues, and then adding delirium on top of that can really throw a curveball to taking care of these patients safely. And then again, with long-term care facilities, studies have shown that upwards of 45% of all patients are suffering from delirium. So again, are we really seeing the true issues that are going on with the patient, or are we just making assumptions that this is really how the patient is? So again, if you're noticing signs of change, making sure that you're alerting someone, or if family members are telling you that this is a different way that their loved one is behaving, making sure and taking that into account as well, and then possibly passing on that information if they haven't told anybody else. Vital signs. PTs, we can provide a lot of insight into how the patient responds to activity. Since this is our job and this is what we do day in and day out, we can make sure and glean information regarding the patient's tolerance to any sort of upright activities, functional mobility, and tolerance to activities. Specifically in regards to the heart, speaking of the heart rate reserve, this is defined as how much the heart can increase its rate from the resting value to respond to demand. It reflects the heart's ability to increase cardiac output. And to get the heart rate reserve, you take the resting heart rate from the maximal heart rate. And I assume you all know how to find max heart rate, right? 220 minus the patient's age to find that max heart rate. So making sure that you understand what that heart rate reserve is. Because again, if you have an older patient, 80, 90-year-olds, if you take 220 minus that age and factor that resting heart rate from that number, they don't have much room to go from their resting heart rate up to their max range without getting extremely fatigued. So knowing what that is to determine how they're going to do with ambulation activities, say in their home environment or in their community, would be important to know. Also knowing the patient's blood pressure and if they have any hypertensive type issues or problems or have been dealing with that in the past is going to be important to know as well when working with our patient. Do we know if the patients have good blood flow to their tissues? Because this is definitely going to impact any healing or mobility activities that we want to do with our patients. And it just lets us understand the heart health, understand what's going on with the heart health of our patient. Thinking about the layers of the heart itself, smooth muscle is going to change with age and activity level, as well as other lifestyle factors throughout their life. And if the artery wall is pretty rigid, there's not as much ability for the heart to pump, and therefore the blood to move oxygen throughout the body as appropriately as with somebody that's healthier or younger. Orthostatic hypotension, I'm sure you guys are very well familiar with orthostatic hypotension. That's defined as a decrease in systolic blood pressure by 20 milligrams or a drop of 10 millimeters of mercury with a reflexive increase in heart rate with any sort of transitional movements. The causes of this could be hypotension, adverse effects of medication, dehydration, anemia, central nervous system impairments, immobility, all those kinds of things. And if you're working with somebody that's medically complex or acute, you're definitely going to see some of these in your patients. The patient may or may not be symptomatic, so just making sure that you're asking those kind of questions when you work with the patient, and just being aware of what their blood pressure is. It's important, especially when you're working with these types of patients, to be mindful of what their blood pressure is when they're in a seated or supine position, and then when you're moving about trying to do other activities. So if they're in the hospital bed, making sure that you understand what their blood pressure is when they're lying down, and then as you get them up, starting to look at that as well. The CDC has different ways and different information that you can give to the patient to understand kind of their heart health and ways to improve their heart health now and into the future. This link shows you some information. There's all kinds of information you can share with their patient, and all kinds of other links that you can go to from there, again, to educate yourself and or your patients or family members. A lot of times, many of our patients will have a heart age that's greater than their actual age due to all kinds of different reasons. Could be the fact that they're a smoker, could be due to high blood pressure, maybe they're diabetic, or have poor weight control and are quite heavy, and that can affect how healthy the heart is going to be as well. Malnutrition is definitely a real issue in the geriatric population. So many of our older adults don't like to eat as much, and this is one thing we'll be discussing later in the semester as well. But when it comes to nutrition and how a patient deals with nutrition as they get older, their sense of taste and smell has changed quite a bit, so therefore they're not as hungry and don't want to eat as much, but that can be really bad for them. Also, if maybe they're a little bit confused and tend to forget whether or not they've eaten, malnutrition can really play a role here. I've had patients in the past that are dealing with some form of dementia, and maybe they just tend to eat foods that aren't the healthiest for them, you know, snack on chips or cookies, crackers, that sort of thing, but aren't really getting real protein in their body. And so making sure that we're asking the right kind of questions of our patients and or family members to understand and help educate them. Because again, if we're their point of contact, we need to be the one that steps up and helps them with some of their nutritional needs. We're not expected to be a dietitian, and I don't expect you all to be one, but just being aware of that can really affect how the patients are going to react with you in therapy as well. Study shows that nutritional status in older adults where they were malnourished or at risk of malnutrition is a very high problem that we have with our geriatric population, and something that we need to be mindful of. 62% of hospitalized older adults are protein deficient with very low pre-albumin and albumin levels. Therefore, if they've got those low levels and don't have enough protein in their body, they're not going to have the energy stores to do what we need them to do in therapy or to be functional at home as well. So if they're not getting that healthy protein, we need to make sure that we're being mindful of what they safely can do. Monitoring prealbumin levels is very important, and a lot of times with these medically complex patients, when they're running their blood work, they are looking at this, and so most hospital staff are on the lookout to see if there's an adjustment in their nutritional or fluid needs based on these numbers to support proper healing in the body. Here's some standard ranges that your book talks about when it comes to heart health and blood health, and oxygen and lung health as well. So just knowing what these normal values are, so that way if you see something that's out of range when it comes to your patient's values, you kind of know what to expect when it comes to how they might react in therapy. Most of the times though, with our reports that we get on their values, it will tell us whether or not they're high or low or in the normal range, but it's good for you to know as well what those ranges are supposed to be so that you have a better idea, especially if the patient doesn't come in, especially in an outpatient setting, and they don't come in with their report itself, but they might tell you that you know, their blood pressure is running at 150 over 120, and we know that that's not normal or right. So making sure that you know what the normal ranges would be. Some specific things that we need to make sure of and terminate treatment if any of the following are observed outside of these normal parameters that we just discussed. So specifically, dizziness that is not resolved within 60 seconds of obtaining an upright position. We need to stop and probably terminate any therapy that's going on. An increase in the patient's heart rate of more than 30 beats per minute or more over their baseline. We need to stop therapy. A change in the patient's systolic blood pressure of 30 milligrams of mercury or a change in the diastolic pressure of 10, we need to stop treatment as well. If the patient starts to have blurred vision, dilated pupils, angina, or shortness of breath. Now, shortness of breath might be one of those things that we take into consideration and see if we can wait it out, see if the patient gets better with, maybe some deep breathing, maybe they're anxious, a little bit nervous, or maybe they've hit kind of their threshold for tolerance, and maybe if we can let them rest, that gets better, and then you can continue on with therapy. But definitely the top half of those things, or everything above that shortness of breath, needs to be taken into account, and we need to terminate therapy if we're seeing that. If we are seeing that and decide to terminate therapy, we do need to make sure that we're letting hospital providers, nurses know what's going on with them so they can make sure that they're keeping an eye on them as well. These next three screens are discussion cases. I want you to read over each of the next three discussion cases and make sure that you understand what the patients look like, understanding their lab values and vital signs, and determine whether or not you think the patient is appropriate for intervention. This is one of the things we'll be discussing in lab come our next class period. So look over each one of these and get your thoughts in line, and then we will discuss at our next session. So make sure you look through all those different cases. There's just 3 different cases. And then we will go from there.